Hello, my name is Reef. I'm 2 years old.
Veer's a real character. He's smart, funny, adventurous, full of beans, and he's very cheeky. But underneath his healthy exterior, Veer's body has been hiding a very rare genetic disorder.
I got anemia. You gonna help me?
This means that his bone marrow is not producing enough stem cells, and so his blood counts are dropping. He will always have a higher risk of certain cancers, but soon he will need a stem cell transplant. Due to his Asian origin, Veer only has a 20% chance of finding a good match. Unfortunately, no one in our family is a match, so now we are relying on the generosity of an unrelated stem cell donor from anywhere in the world. All it takes to register to become a donor is a cheek swab. You have the rare opportunity to save a life of someone like Veer's, so why not take it? There really couldn't be an easier way to save a life.
Community Assistant Team 8, CAT8,
is a group of Jain individuals and professionals
who are assisting the community at large
during the COVID-19 crisis.
CAT8 began just before the COVID-19 crisis,
when it held a can challenge,
Where children created iconic monuments.
Using cans of food. It raised some 3 tons of canned food. Enough supplies for 4 months.
for the Watford Food Bank, run by the Trussell Trust.
During the COVID-19 crisis,
CAT8 is helping the elderly, the vulnerable.
Those with isolation and key workers.
with meals and essential shopping.
Help with medicine collection.
and someone to talk to.
whilst coping with isolation.
CAT8 is organising webinars,
imparting information and creating awareness.
A range of topics for all age groups.
In addition, we have created
A business and education helpline
For individuals and businesses
that need further guidance
on the topics of all the webinars.
we also have a YouTube channel,
a Facebook page and a Twitter handle.
CAT8 is a newest network fibre,
Connecting the community.
We are also very kindly and generously supported by a number of businesses to enable us to carry out our work. Thank you. Our speakers today are Dr. Ameet Bakhai, Dr. Rajvee Punata, and Dr. Anuja Shah. Ameet, many of you may already know, is a consultant cardiologist and a cardiovascular R&D director at the Royal Free London NHS Trust. He's also a Harvard Scholar and a Fellow of the Royal College of Physicians and the European Society of Cardiology. He has enabled innovation of drugs, devices, diagnostics in multiple cardiac areas of heart failure, arterial fibrillation, acute coronary syndromes, and the risk factor reduction for cardiovascular events. He has published over 100 papers and received a national award for a decade of work in clinical cardiovascular research from the Royal College of Physicians, and is a recognized clinical trials and research, technology, innovation, and medical education. Dr. Rajvee Punata has worked in the field of cancer research for over 20 years and is currently the principal research scientist at the world-renowned Francis Crick Institute in London. She studies how DNA is repaired after being damaged and how defects in this process can lead to cancer. Rajvee has published her work in major scientific journals. Since March this year, the Francis Crick Institute has diverted considerable resources and expertise to become a COVID-19 center for frontline healthcare workers, and more recently, a COVID-19 vaccination hub. Rajvee has volunteered to be part of this effort. Rajvee is the current chair of a charity called Sansa, which promotes the learning of Gujarati language and culture through the fun and music and play for children. On a more personal note, Rajvee's family experienced the tragedy of losing a close family member to COVID-19 during the first wave in March. Dr. Anuja Shah is a general practitioner. She is a GP partner and trainer at the Wheatfield Surgery in Luton. She is also the palliative care lead and a primary care network lead. She has special interest in diabetes and women's health. She will be involved in administering the COVID-19 vaccine. So without further ado, I will hand over to Ameet.
Thank you so much, Ramit and CAT8 for allowing us to do this. I'm just going to move over to the screen, sharing my screen. Can you hear me okay? Can everyone hear me okay?
Yeah, it's fine.
Amit, we can hear you.
Thanks, Ramit. I'm just going to move to full screen now. And as I do that, I want to thank everyone for joining us from all over the world, and more importantly, for wanting to be aware of what it is that we are facing at the present time, called COVID-19. Just moving to my screen now. Okay, so we're going to go through three aspects at the moment. One is about understanding the disease. Another is about understanding the research and how vaccines are created. And the third is about how the vaccine delivery will occur and the common things to think about if you've had a COVID infection, after the infection, or to avoid the infection. And the three messages that we want to give you today are very simple. Number one, stay aware, which is why you're here. So thank you for making it, but also keep aware the people who didn't make it today and who you may want to talk to. So stay aware, have awareness, gain correct knowledge, and be communicative about the things that are concerning you. The second message is stay calm and positive and hopeful. This calm is needed because actually, if we panic, if we do the wrong things, if we misbehave, if we try to rush things and take shortcuts, whatever we're trying to do, there is often a risk that we will harm yourself and others in that message. So staying calm. And then the third part is staying safe. And this whole presentation for our community is to prevent you ever seeing me in a hospital setting, ever seeing Rajvee in a research setting, or ever seeing Anuja in primary care unannounced as an emergency. So this is why prevention is far better than cure. And that's why I'm very appreciative of features like CAT8 and the Navnath community and the Oshwal community, all of the people who as a community are looking after its members. So it's a great thing to be joined up for health and science reasons. With that, I'm going to take you through COVID. Please understand I'm not a virologist, I'm not an immunologist. However, as a research director, I support all of the COVID research occurring at our hospital, and I'm actually responsible for 2 trials that have recruited really well in COVID-19. So let's take a look at what is COVID. So in terms of a virus, understanding that a virus is an incredibly beautiful thing. It has one simple purpose: find somebody, infect them, make copies of you, and then push out in terms of replicating itself. A virus sadly does not have the ability to replicate on its own. it requires somebody else to manufacture the virus to do so. And usually the virus consists of two features. One is a template called an RNA, which is how do you make me? It is the blueprint by which you make me. The second is usually a capsule. Now, that capsule is just to keep that viral template protected. And that's it. It's the most elegant, the most simplest mechanism of saying, here, photocopy me, and I just want to be everywhere all the time. What's really amazing is it is the only thing we found that can infect a bacteria and kill bacteria, and that's how we found out about viruses 70 years ago. It was considered a bacteriophage. Now, this particular virus, COVID-19, which actually sits happily in bats, actually moved across to humans, and we think it moved through this scaly anteater called a pangolin, and we think this happened in Wuhan, China, and then from that host, from that animal itself, it's arrived in humans. And it's got an advantage. It has a particular protein called a spike protein at the top, which attaches into our lung tissue. And there are ACE inhibitor receptors in our lungs that are normally there to help us to expand our airways as we need and decrease those airways. The elasticity of the muscles in the airways, ACE receptors are there. And actually this particular virus spikes onto it, hangs in there, and then goes inside and uses our lung tissue to multiply. This would not normally be a problem, and it can live within us, it can actually multiply within us, and we can get over the infection in 5 to 14 days. Now remember that day 5 that I've just explained to you, okay? However, what happens in a few of us, 15 to 20% of us, you get an overreaction of that healing. So let's take you through the next slide on that. Here is this idea that the virus gets in on the left-hand side. It gets inside our cells, it releases this photocopy mRNA, then uses all the material that's existing within our own cells to say, make lots of copies and go outside. Normally, this would not be a problem. We can survive it, we can live through it, but about 1 in 5 people will actually overreact and get a very massive problem. I'm going to show you at the top here 2 x-rays. Now, this is a person who you're going to see potentially on a video later on. On the right-hand side is this gentleman, is a 62-year-old man. It's his chest x-ray a month and a half after he's healed from COVID. And what you can see is the heart in the middle and these spaces either side of the heart where the ribs are there going across. And then you can see these nice, dark, clean spaces. If you look at the left-hand side x-ray, which actually is in September when he actually first came in, this is his x-ray with lots of shadows in the periphery, little bat's wing shadows going out from the heart. This is his lung being damaged. And on the right-hand side at the bottom, you can see a CT scan. And in the middle is a black hole, and either side are these dark patches. Now, those dark patches are meant to be entirely clear and entirely clean. What you can see is all these paintings of lines around it, little gaps where the lung has actually been made a cyst. Now, I want you to understand this term C-reactive protein very quickly. C-reactive protein is the war zone in your blood. And what you can see is that normal level should be below 5 in all of us. And so if ever you want to know if you're unhealthy, go to primary care and say, I need a C-reactive protein to see if I'm unhealthy or not, particularly badly. What you can see here, when he came into hospital, it was 100, then he was getting better, and then you see another spike going up, he's getting worse, he goes to ITU, he gets some therapy in ITU, and then he becomes well again, and then goes home. So this is the normal course of effects. Now, if that second spike had not come down, and it goes back up, 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 patient passes away. And so that is the way to check. Now, ITU consultants like my friend Tony Wolf said to us, this is not a normal pneumonia. In a normal pneumonia, you can ventilate somebody, you can take out the fluid that's spare in the lungs, and actually you can push lots of oxygen through the ventilator machine, it will get into the air and you'll be able to carry oxygen. There's something unusual about COVID-19 that makes it really sticky, makes the lung tissue very stiff. So you've got a gluey set of fluid and you've got a very stiff lung to make it really hard to punch through a ventilator oxygen into that. And in fact, when we were punching really hard, we were actually harming the lung tissue permanently. And those patients were doing worse in ITU on a ventilator. So the death rate if you had to go onto a ventilator at the time of April was 1 in 2 people wouldn't make it off a ventilator with COVID-19. So 50, 60% of people were actually not making it until we got new therapies through research. This is, I don't expect you to read this, but it'll be in the YouTube video. On the left-hand side, you can see these air pockets. At the top, in the middle of the graph, you've got these beautiful hollow air pockets where air goes in and out, mixes through the wall of the tissue itself with some blood vessels to move oxygen in and carbon dioxide out. What you can see as you go to the bottom, to the left-hand side, these hollow bags are filled with this yellow liquid, this serum, this inflammatory war process and the leftover pollution of war. And so the lungs are getting really abused, really sticky, and you can see these horrible fluffy things on the right. Now you can see on the left-hand side in the very top here, this is a coral reef, a beautiful normal coral reef on the top left picture. That's what, if you ever go diving into Nyali Beach or any of those beautiful beaches in Mombasa, this is what you will see at the base if everything's going well. The next picture on the right is the coral reef degenerating, because now you're seeing all these inflammatory war zones for the coral being bitten. And each picture there shows you in more detail exactly how the architecture of the sponge is being damaged. On the right-hand side, you can see I've given you 2 CT scans at the top and 2 X-rays. The left-hand side of each one is normal, and the right-hand side is scarred, just as we saw with that other patient who's 62. This particular infographic is the normal course of events. What I said to you is that you will have symptoms between 5 to 14 days, and most people's symptoms will resolve within 10 days. So this 10-day isolation period that we've had many a time. Actually, most of the time, 5 days before you get symptoms, you will be passing and transmitting potential vector of virus to other people. So you're actually able to transmit 5 days before you even knew you had COVID. So that's quite important. If you particularly want to isolate before you see your parents or grandparents over Christmas, 14 days of isolation to make sure you've had no symptoms during that time, you'll be fine. Even potentially 10 days, but 14 days is absolutely perfect. At the top, in the middle, you can see the viral genome multiplying in your body, and then it should come down. What happens in that middle curve, the mild to moderate illness, is that's 80% of people, 4 out of 5. However, you'll get this severe and critical illness and death potentially in up to 2 to 4% of people. And this illness is in so 1 out of 25 people will not make it with COVID-19, but 1 out of 5 will need hospitalization for oxygen or ventilation. Antibodies start occurring within 3 days, but they're at good levels, usually after about 12 to 14 days. So you see that you're building up immunity if you get through it. Here is a really nice infographic that if you're mild, if you're less than 50, if you're young, you get mild disease, you get over it very quickly. You may get some fatigue, you may get some dry cough during the time, but then you get through it. If you get severe, you may need to come into hospital, have oxygen ITU and a ventilator potentially. And the elderly are much more at risk, not only of being hospitalized, but of a bad reaction. They can't actually, they are overwhelmed by trying to fight the virus, and the war itself actually costs their body the toll and the energy loss, and that's why they pass away. So that's what it's all about. Here on the right-hand side, I'm showing you in plain English who are the people who would be at risk. So we've said the elderly. We've also got studies now that Black and ethnic minorities, Asians, particularly like us, are at increased risk by about 2-fold. We've also seen in the UK, the Pakistani and Bangladeshi community are really even higher at risk than we are. And there's a lot of factors for that, but it's really unfair on those communities because they're not only getting these infections at higher rates and getting deaths, but there are often people that are working in the sectors that might expose them to this virus from others. If you have diabetes, if you have high blood pressure, if you have existing lung disease, existing heart disease, if you're obese, if you're unfit and you don't do breathing yoga techniques, you don't go for long walks, you don't do cycling, you don't do rowing or swimming, if you don't do these fitness things, if you're a sedentary individual that basically sits on Zoom calls most of the day, like some of us do, then that is actually not a good place for you to get COVID. COVID is a challenge to the body. You need to be able to clear your lungs really quickly. So kidney disease patients, particularly worrying about dialysis patients, It's a really tough time for them because they are going in and out of hospital if they're on hemodialysis, and they are at risk of catching it and actually not surviving through it. So those are the people we need to worry about. And then, of course, pregnant people who have coexisting lung and heart disease. Here is that data I told you about race. You can see the Bangladeshi community, the Pakistani community, the Asian community. You know, we're at much more risk than whites, Caucasians. And Afro-Caribbeans are also at particularly high risk. And we'll see that they also get high blood pressure. So they punch holes in their blood vessels. The blood vessels are open, and the viral war zone can get inside the blood vessels, and they get sequelae from that. They get slow blood. Here in this slide, this is over 4 years. And what you can see, this is tracking 1 million patients in this country, 1 million people with diabetes, type 2 diabetes in this country. And you can see the death rates spring up every January, December, because that's the flu season. That's the winter flu season. What you see in the very right-hand side of the graph is, look at that. COVID has completely gone 2.5 times higher than any death rate across any peak of a flu season. And we are just lucky that that first wave in March and April didn't come during December and January. Had that come on top of a flu wave, a COVID wave on top of a flu wave, the NHS would have collapsed. We would all have even more deaths than the 64,000 odd deaths that we've registered at the moment in this England and Wales country. Okay, from our almost 1.8 million infections in this country alone. And so you can see that diabetics are at higher risk, particularly diabetics with weak hearts and those who've had strokes before and bad diabetes control. So if your sugars, your HbA1c, you've got that level that you need to check is above 83, you're particularly at risk. Now, this is really important. The next winter season flu is around the corner. It's now. Get your flu jab and avoid the flu, because if you get flu and we have a second COVID wave because we've allowed people to mix over Christmas, we're not going to cope. And so that's a really key message about staying safe. Don't gamble unnecessarily with those people. Just to prove that, I actually have a slide here that says, I've jumped a few slides. Look at this. If you're a 75 to 84-year-old, so that's my mother, some people's grandparent, you are at 8 times higher risk of hospitalization than a 18 to 29-year-old. More importantly, your chance of getting death from COVID is 220 times. So if you're thinking of going to see your grandparent and you may have COVID, you are putting them at incredibly high risks. So every time you do that, please have PPE safety. Please think less than 10 minutes. Please think 2 meters distance. Or is it really necessary to have to mingle if they're isolating and they're vulnerable? So that is a really important chart of vulnerability. The hospitalization rates and the death rates, the older you get, the worse the situation. Now, we are lucky that we've got trials like the recovery trial, which we are the first country in the world that has a unified 175 hospitals, 11,500 patients. By June, we already knew that dexamethasone, a steroid that reduces you overreacting to things, actually can help those people that need oxygen or a ventilator. And so we're blessed to see that 1/3 of ventilated patients, given a cheap, simple medication that we've had for decades, actually help them survive better. 1 in 3 people were saved through that, or 1 in 5 receiving oxygen. We are the only country in the world that was the first to show this incredible result, the recovery trial. And those people, Martin Landray and colleagues, will probably get some sort of Nobel Prize at some point. So we're lucky. We're also lucky that we locked down in March. Look at that, 23rd of March. So even prior to that, we were lucky to have a health and science board like ourselves telling our community no more physical events in March. We actually prevented a whole load of people dying in April, even though some people still passed away. But that first lockdown worked. And actually this idea in this country that we've said over Christmas for 5 days, hey, do whatever you want, we're not really sure that's the right thing. If it was up to us, we'd have a lockdown Diwali as we did. And guess what? Diwali for us didn't cause a massive spike of deaths and hasn't yet caused a massive spike of admissions from our group. But over Christmas, this country has said, tell you what, you can get together with families. Not sure about that. Okay, so it works. Now, more importantly, we were also seeing that the rates of admissions for non-COVID things did not catch up during COVID. So there was a backlog of people with missed cancer, a backlog of people with missed heart attacks. Those people were so scared they didn't come into hospital, they were delayed through the services, the scans were moved later, don't come into hospital. And actually what we're worried about is a rebound effect of heart disease and cancer disease actually waiting out there that has been delayed in its management. So please don't fall into that delay trap. And that's why the NHS at the moment is trying to do both things in parallel. The return to normality of cancer and heart services, etc., and particularly life-threatening illnesses, plus also trying to manage COVID. So we've gone through this. This is just a little slide to help you as an infographic to say, remember I told you about that day 5. Now, normally the flu, the seasonal flu, which will kill only 1 in 100 elderly person or vulnerable patient, will usually do things, get all its symptoms out of the way. Pretty much heavy symptoms will occur within the first 2 to 5 days. And it doesn't have very often this loss of smell or taste, which COVID has had. The cold, 2 to 3 days, you'll get over it as a normal person, etc. But beyond, if you're getting the 5 to 14 days of symptoms, if you're getting the cough, if you're getting the smell, but not so much the sneeze, it's more likely you've got COVID. So here is a distinguisher between the flu, the common cold, and coronavirus, COVID-19. That smell, that beyond 5 days, that more cough, a dry, hacking, horrible cough with breathlessness and fatigue, rather than the sneeze and the sniffle and the runny nose. Okay, that's much more a cold. Okay, and then there's this thing called long COVID, which is we have now found 60,000 people 3 months beyond their initial COVID infection are still tired, still breathless, still depressed, still getting chest pains or fast heartbeats. They can't cope with energy levels, they can't move, they can't get up without getting fast breath or fast heart rates, etc. And that is now becoming a recognized entity. If you have long COVID, if you have persisting symptoms beyond the sort of 3-month window, I want you to go to the primary care team and have some blood tests. Make sure you haven't got clots in your lung. Make sure you haven't got a heart function that's weakened by COVID. Make sure your lungs are actually still not are over that. Get that CRP test done. Get an NT-proBNP level done, and get a D-dimer done to make sure that these simple blood tests will identify if you're getting clots in your lung holding you back or a weakened heart. These are the late stage effects of COVID. So I'm not going to overwhelm you so much there. I'm going to stop there and say to you that these are the key messages that I've tried to impart to you. That COVID-19 is highly effective at causing lung damage, which if you're a healthy person, you should be able to get over. You should be able to stop yourself overreacting to COVID. Now, there is a genetic tendency of about 5% that may overreact, but other than that, it's about fitness. It's about vulnerability. It's about age. It's about diabetes. It's about high blood pressure. It's about being Black and ethnic minority. Those people are at high risk, so please take care of them. Now, PPE works. It's worked for us in hospitals. It's worked for patients. It's worked in the general public. Please use it. We're lucky to have some affordable treatments at the moment, and we're brilliantly hoping that this next year, vaccines will shed a great new light on, allowing us to arrive at a better new normality. But that message still should not be, do what the hell you want. You are in control of our future. If you stay calm, if you stay aware, and you stay safe, that's going to be the most important things you take away. So I'm going to hand it across to my great friend Rajvee. And one of the reasons I've got this particular background at the moment, which is the highest sunrise in Kilimanjaro, is that the 3 families, Rajvee Punatar and her family, myself and my family, and Anuja, all of us were involved in climbing Kilimanjaro 2 years ago. And the funny thing there is, this is the picture Rajvee's daughter took, which is the most incredible picture I can never get away from. I love it all the time. And that last day going up Kilimanjaro, being breathless at 80% saturations, that is actually how COVID patients feel all the time when they're in hospital, having to lie on their front for 7 to 10 days. I don't know how they cope and get through this. You know, I'm so amazed at people who get through COVID and recover as heroes. So that is the connection to that background there. And it's my pleasure to hand it over to my good friend and great scientist, Rajvee Shah. Rajvee, take it away. Thank you so much.
Hi, Raju.
Hello, everyone. Can everyone hear myself? Thank you, Ameet, for that great introduction to COVID as a disease and how it affects our community. So today I'm going to talk to you about the role of scientific research and vaccines in fighting COVID. And this is where I work. Oops. So I work at the Francis Crick Institute, which is housed in central London opposite St Pancras International. It's the largest biomedical research facility built under a single roof in Europe. And it's state-of-the-art, opened in 2016. It's very big, has 1 million square feet of space. And within it, 1,250 scientists from 70 countries work, mainly on different areas of research and all to do with human health and disease. So these two pictures are from within the Crick Institute. So we work on diseases such as cancer, heart disease, Alzheimer's, and dementia. But we also work on infectious diseases such as malaria, tuberculosis, and HIV. We also house the World Influenza Centre, which is where, working together with the WHO, the World Health Organization, our scientists help design the flu jabs that everyone takes each year. They have to be changed every year because the flu virus is circulating, change every year. So like many other places of work and other institutes, when the first lockdown happened in March, our institute was also shut down. But what we decided to do, and the scientists there decided to do, was to join and help the effort, the COVID pandemic effort, the best way that we could. And many of our scientists and clinicians work with hospitals around London, and what they were seeing was their colleagues in the hospitals were struggling to get tests, PCR tests for COVID. That meant people were having to stay home when they didn't know whether they had COVID. And the other thing was that if they did have COVID and they weren't symptomatic, they were a risk to patients. So what our scientists decided to do was to set up a testing pipeline for COVID. And this was specifically for NHS frontline staff and patients. And it's been extended since then. We had to do this from scratch within the first weeks of lockdown. And this was an amazing effort. 700 of our staff volunteered, working in shifts, including weekends and evenings, to set this up. And so far we've completed 200,000 tests, and we are serving 10 hospitals and 150 care homes. In June, when the lockdown was lifted, we were allowed to come back into the Crick in waves. And the reason that this was made possible and safe for us is that as a staff member, I also have weekly COVID PCR testing. I take a swab kit home with me, and then the next morning I swab myself. I pop it in a special tube and a little envelope, which has got its own unique barcode that is for me. And within 8 hours, I get my result. And I know this isn't something that everyone can have, but because of this, we've been able to keep the Crick open and do some very vital research. And the other thing that we have had is one-off antibody testing. As was mentioned by Rumit earlier, our family did suffer from COVID in the early days, and this antibody testing confirmed that I am seropositive for COVID antibodies. So the other thing that's happened, and this is common with many, many scientific research institutes all over the world, is that we have been able to sort of concentrate our efforts into COVID research at the Crick. So there on the left, what you see is a diagram, and it's an image of the COVID virus, the coronavirus, and its actual proper name is Severe Acute Respiratory Syndrome Coronavirus 2, so SARS-CoV-2. That's the proper name for it. And as you see it's spherical, and you can see these little red spikes that Ameet referred to, which are the key to how it infects us. So what sort of things do we need to know? It's very, very new, as you know. It was only first identified in November, and scientists quickly sequenced its genetic code in January. So 23 different research groups are actually helping to identify vaccines and new treatments for this within the Crick. And they're asking questions and trying to answer questions such as, how does it infect our cells? How is coronavirus transmitted, and is it evolving? Why are some cases much worse than others? That's something that Ameet alluded to earlier. And can lifestyle and ethnicity make the disease more severe? So we know this happens, but we don't know why. And what the scientists are trying to do is understand why, at the molecular level, these differences are happening. I'm just going to click off there we are. So now I'm going to talk to you about vaccines, which is why I'm sure many of you are here, because it's all over the news. And I'm just going to first tell you a little bit about vaccines and what we already know about them. The first thing is they are widely considered to be one of the greatest medical achievements of the modern world. And every year they stop an estimated 2 to 3 million deaths, and they prevent more than 20 life-threatening diseases. And childhood illnesses such as polio and measles that were really common in the days of our parents and grandparents, that was less than a generation ago, these diseases are now very rare due to immunizations. And smallpox, which probably started off millennia ago, they have found mummies in Egyptian tombs that have got traces of smallpox, is now completely eradicated, again, through to vaccines. Now, if you want to see a real-time way of measuring how vaccination can have a profound effect on disease, I just wanted to show you this graph. So along, I don't know if I can see, along this axis here, as you can see, at the bottom is 2020, where we are now. We're going back in time as you go further up. And these are the diseases that were prevalent at the early part of last century: diphtheria, whooping cough, and measles. And what you're showing here is the size of these red circles is representing the number of cases. And what you can see in 1942, if you look at the diphtheria one, there were 41,000 or more cases of diphtheria. And 1942 is the year that the vaccine was introduced and mass vaccination happened. This is in England and Wales. All this data is for England and Wales. And what you can see is from 1942 onwards, there was a massive drop in the number of cases to right down at the bottom, 2019, only 10 cases. Similar results with whooping cough. And then right at the end, we've got measles. Now, measles is very rife. It's very, very infectious. People talk about R numbers. Our number for measles is 15. I mean, that's really high. And that's why in 1968, there were over 236,000 cases of measles. As soon as in that same year, the vaccine was introduced, look at the drop off. When you get back down to 2019, just over 2,000 cases. So this is how effective mass vaccination has been in the past. So how do vaccines work? So just as a reminder, I'm sure many of you have heard and read about this on news sites, but vaccines train your immune system to create antibodies that will protect you from a disease even before you've had the disease. It's much safer for your immune system to learn to make antibodies through vaccination than by catching disease. The two main reasons are, first of all, you don't risk having severe permanent damage or dying. And secondly, it's a way to get antibodies without you being in a position where you could be passing the disease to other people while you yourself are trying to recover from it. Once your immune system knows how to fight a disease after you've been vaccinated, it remembers. So what this means is if you really do get the disease afterwards, your immune system can kick into action straight away and not have to wait the 5 or 6 days that would normally happen if you first saw it or if you hadn't had a vaccine. Let me talk a little bit about herd immunity. So having a vaccine not only benefits you, but it can benefit your whole community if enough of us take it. So what this means is if enough people are vaccinated, it's really hard for the disease to spread and it's really key because there are some people who cannot have the vaccine. So for example, if they're ill or if they have a weakened or compromised immune system. So what is the herd immunity levels? It depends on how infectious a disease is. But for COVID-19, coronavirus COVID-19, 60 to 70% of the population would need to be vaccinated to achieve herd immunity. And I just want to make this point here. As far as we know, and as far as all the data has shown, herd immunity has only been achieved through vaccination, never by people just being able to get the disease. So let's just look at the types of vaccines. So this is a table. I just want you to look at the graphics at the top. So the two main types of vaccines that were first sort of discovered and used, and some of them are still being used, are what we called live attenuated or inactivated vaccines. They're basically the form of the virus that's either been disabled in some way, so it's weaker, or it's been completely killed. And there are examples on the second row of the table there. So you've got examples of MMR is a live attenuated vaccine, and polio is an inactivated vaccine. So these are the traditional ways that vaccines were made. There's another type of vaccine that's been made more recently, and it's more common, is a subunit. So if you had a coronavirus, if you imagine these vaccines at the top was a coronavirus and these red spikes are the spike protein, what you would do is only introduce the spike protein in the vaccine. No need to introduce the whole dead or attenuated organism. So you take the bit of the virus that is going to help to make the antibodies and only put that in. And examples are pertussis, hepatitis B, meningitis B. So let's come on to viral vectors, because this is a fairly a newer way of making basically a vaccine. And what they do is they actually deliver the viral genes to our bodies within a harmless virus. And this has been used by Ebola. And I say for all of these methods, at the bottom there in green writing, what you can see is all of these different companies are trying to make vaccines against coronavirus COVID-19 using these methods. And here you can see at the bottom under the viral vector, the Oxford University AstraZeneca vaccine that is in the media right now. This is how it's made. But the newest kid on the block that people are talking about are the messenger RNA vaccines. And they belong to this group of DNA and RNA vaccines, which have actually not been made before until this year. So I'm going to talk a little bit more about that, but just to say that the Pfizer vaccine, the BioNTech Pfizer, and the Moderna vaccine are messenger RNA vaccines. So how do the messenger RNA vaccines work? Well, basically, here you have your coronavirus and here's a spike protein. And because the scientists had sequenced the genetic code so quickly to coronavirus, they were able to identify the gene for the spike protein. Using that information, they make the messenger RNA sequence for the spike protein. They coat it within a lipid coating. They then put it in your vial for injection. This gets injected into our bodies. And what happens is, this is a very clever system. When it goes into our cells, the cell's own machinery actually makes the spike protein. So we become basically a vaccine factory. And the spike protein then is made. It's made just for a few days. It's not there forever. It just makes for a few days. But that is long enough for our bodies to mount a massive immune response. And antibodies get made to it. And later on, the rest of the immune system also makes, as we might have heard of, the T cells, which actually help to destroy the spike protein. So that's how messenger RNA vaccines work. They're very specific. They only use the gene that is only for the spike protein. So I've actually gone through these. So all of these vaccines, especially in the last few days, this vaccine from Pfizer is all over the news because they've published the results of their clinical trials. So why are clinical trials important? Well, they tell us how effective a vaccine is and how safe it is. So I'm just going to give you a summary of what the phase 3 trial of this Pfizer messenger RNA vaccine showed us. So what they did was 44,000 volunteers took part in this trial. Half of them received the vaccine and half of them received something else, a placebo, which is basically not the vaccine. And they both groups got 2 doses. This trial was double-blind and randomized. What does that mean? That basically means that the participants don't know which one they're getting. The people who are giving them don't know which one they're getting. The whole thing is decided by computer. The computer gives a code, and the code tells the person what vial to give to what person. And this is the best way to do it because people can be biased in themselves if they think they're getting the vaccine or if they think they're getting the placebo. The other thing I should say is equal numbers of people who got the vaccine or placebo, equal numbers in all the age groups, different ethnicities, where they're living. So everything else should be equal. And what they found was after 2 months, 170 of these 44,000 contracted COVID-19. This would have just been due through them going about their normal business in the day. And what you want to know is, if a vaccine's really good, most of these people who got the COVID-19 would have been in the placebo group. And in fact, that is what was found. In fact, the results were absolutely amazing. So what you can see in this table, of the 170 people that got COVID-19, 162 of them were in the group that did not get the vaccine. Only 8 of them who got the vaccine got COVID. So what this tells us is that's how they work out. The vaccine provides 95% protection against COVID-19. And there were no adverse reactions that were observed in these participants over 2 months. And I know there has been some reports of people having an allergic reaction, and I think Anuja is later in the next bit is going to address that. So if you compare the vaccines that are almost ready, there's the Pfizer-BioNTech at the top, the Moderna one, the AstraZeneca one. They're all quite effective. They have varying costs. These are all the numbers of people that took place in their phase 3 trials. There's differences in how they're stored. The AstraZeneca one, as you can see, is only £3 cost because they're basically doing it at cost price. So now, some of the vaccine myths on social media. There are a lot. I'm just going to sort of address some of the more extreme ones. First of all, there are videos going around saying it will alter your DNA. There's another one that says it contains a microchip. Another one says the vaccine contains human fetal tissue. All of these look very slick. They look very convincing, but I need to tell you this. They are all false. This is not true. There is no basis. There's no scientific evidence. It's never been shown before. They're very, very alarming. So my message to all of you is please, please do not forward or share these videos and messages. People ask, are COVID vaccines safe? So I want to say to you, no vaccine or drug is 100% safe, and every effective medicine has unwanted effects. The benefits of vaccines far outweigh the risks. So what I want to say to you is, so far in the UK, 1 in 1,000 people has already died after being infected with coronavirus during the pandemic. And if you look at people who catch COVID-19, 3 in 100 die. And those are the facts from what we have seen already this year. If you want to look at about allergic reactions across all vaccines, the WHO has estimated that 1 to 2 people per million have a serious allergic reaction to any vaccine. So therefore, if you look at that risk, you're more likely to be struck by lightning and you're more likely to be in a car accident. So I'm telling you all of this as a scientist, and I look at this as a scientist because many of these same questions I was asking myself. How safe is it? And how effective it is? So for me, I'm going to be taking this vaccine whenever I'm able to. My parents will be taking the coronavirus. But the one person who I can't say, please take this vaccine, is my mother-in-law. In March this year, 1 week before lockdown, our family started coming down with coronavirus symptoms, although we didn't really know what it was at the time. All of us, there's 6 of us, or were 6 of us in our family, all had different symptoms and different severities. 2 of my children, 1 had no symptoms at all, 1 had loss of taste and smell that Ameet talked about, but we only found out that was a symptom a month or 2 later. My mother-in-law started coughing, even though the rest of us had isolated. We'd done all the wiping down of the house with the wipes. We didn't go anywhere near her for 2 meters. It's really, really infectious, especially if you're isolating at home. It's really difficult to stop other people getting it. Within 5 days, she deteriorated. She was admitted to hospital, but her lungs looked like those glass lungs that Ameet showed you, and they could not save her, and she passed away. So I don't want anyone else to go through this. If she were alive today, I would talk to her and she would take this vaccine. So about taking the vaccine and how it's going to be rolled out, I'm now like to hand over to Anuja for her bit about the primary care. And thank you everyone for your attention.
Thank you, Rajvee. I'm just going to screen share. Thank you, Ameet and Raji, for the very interesting and informative talk. Sorry, just getting my slide.
Raju, can you mute yourself, please?
Sure.
Thanks.
A very hard act to follow, but I will give it my best shot. Excuse the pun. Today I'm going to talk about the role of GPs in the administration of the vaccines. So as Rajvee mentioned, how the COVID vaccine works. In fact, the COVID vaccines are like the London buses. You wait for one and then 3 arrive at the same time, or at least 3 have arrived, one of which has been approved by the MHRA on the 2nd of December. So how does the Pfizer-BioNTech vaccine work? As Rajvee explained, the spike protein from the surface of the virus is covered in a lipid envelope, which is then injected. The body produces antigens, which in turn stimulates your immune response to produce more antibodies, and T cells are stimulated. There's no whole virus or part of the or live virus which is injected. Hence, you cannot get COVID from this. The trial has been done in 6 countries all over the world, and as Raju said, there were 44,000 participants of all ages in this trial, and it was found to be 95% effective. So there are 2 doses given 3 weeks apart. The vaccine has to be stored at -70 degrees centigrade, and once it is stored and it can be transported at between 2 and 8 degrees centigrade, and it has to be stored between 2 and 8 degrees centigrade, which is the normal vaccination fridges that we have in the GP surgeries. But it can only be stored for 5 days at this temperature. So the vaccine is very fragile. Each pack that we receive has 195 vials, and each vial makes 5 doses. So from the time that it leaves its depot and arrives to us, and then the time that we have to use it within, it's literally just 3.5 days. So we have to use it within 3.5 days. So 195 vials, each vial has 5 doses. That means we have to administer 975 vaccines in 3.5 days. The vials have to be diluted with saline, and once it is diluted, it can be it has to be used within 6 hours. So please don't miss your appointment when you make one for the vaccine. Otherwise, we will be wasting these vaccines. The vaccine cannot be frozen again. How long does the protection last? We really don't know for the moment how long it will last and if one requires a booster in the future. But we know that those who are on immunosuppressant drugs or are immunocompromised in any way may not obtain high levels of the antibody needed, and hence they need to be cautious. They should still have the vaccine. So if you're on immunosuppressant drugs, for say rheumatoid arthritis or any other condition, you should still go and have your vaccine. This is also true for anyone on blood thinners such as warfarin or other anticoagulants. You can also have your vaccine. How safe is it? As Rajvee mentioned, there were no safety concerns at all in the trial. But as we all know, there were 2 reported cases of NHS workers having allergic reactions following the vaccine. Both of them had severe allergic reactions in the past and were carrying an adrenaline pen. In fact, they're both doing really well now. Anaphylactic reactions are very rare following vaccines, and as Rajvee mentioned, you're probably more likely to be struck by lightning than having anaphylactic reaction to a vaccine. Following this incident, the MHRA have advised that anyone who has had severe allergic reactions in the past to any vaccine or medication or food, requiring the person to carry an adrenaline pen should not have the vaccine. The side effects are normally mild and self-resolving, mainly local reaction on the arm of pain, swelling or redness along the injection site, and some systemic reactions such as fatigue, headache, fever, joint aches and pains. There will be ongoing monitoring for long-term safety. So who is eligible for the vaccine? The Joint Committee for Vaccines and Immunization have made the following recommendations for vaccination. So any residents of care homes for adults and their carers or adults over the age of 80 are first priority. As you will recall from Ameet's presentation, these were the people who were hit really badly at the peak of the pandemic, and hence these have to be they have to be protected. They are followed by anyone over the age of 75, and then anyone over the age of 70, and those in the extremely vulnerable group. These are the ones that were on the government's shielding list in the peak of the pandemic. These included patients who were receiving chemotherapy for cancer or radiotherapy for lung cancer or any blood cancers. They might have had severe asthma requiring ITU admission in the past, or have had a solid organ transplant in the past. Followed by these, a population over the age of 65, and those between the ages of 16 and 64 with any underlying illness such as diabetes, chronic heart problems, chronic kidney problems, or lung problems. In fact, anyone who's eligible for their annual flu jab should get their COVID-19 vaccine. After this, it is anyone over the age of 60, and then 55, and then 50. My nephew, who is a frontline worker, has already received his first dose and is absolutely fine. Hence, if you're like my mother-in-law who's over 80, your invitation to make an appointment will come soon. But if you're like my husband who's over 50 and not a frontline worker and has no underlying illness, you may have to wait until early next spring to have your vaccine. With the new vaccines being approved, we may find different vaccines are used for different patient groups, just like the flu jabs, where you have different flu jabs for different age groups. So how are the GPs preparing for this? As a GP, I'm very optimistic and in fact excited in some ways to be a part of this massive rollout of vaccine, which the NHS has not seen prior to this. The group of GP surgeries called primary care networks will be working together. This cluster of GP surgeries will have a designated approved site from where the vaccines will be administered. So this can be another GP surgery than your own, or even a school hall or local fire station that may be used for this purpose. As the vaccines are fragile, they have to be kept cold, and hence it's not very easy to transport them to different surgeries or sites. Although the NHS will be providing us mini bags or called laptops to transport a few vaccines to care homes for the elderly to be vaccinated. NHS will send you an invitation for the appointment, and you should not be calling the GP surgeries. But please ensure that you keep your appointment, as it's very important. So what will happen on the day of the vaccine? So when you come for your vaccine, you will be assessed before you get the vaccine. You will be asked if you have had any other vaccination in the last 7 days, or if you have, your vaccine may be deferred. This is because sometimes it can become difficult to determine which vaccine may have caused any side effects. This is not, there may be circumstances where you cannot wait more than 7 days and you will then be given the vaccine. If you've had any severe allergies to food, medication, or vaccines in the past, you may then not be able to have the vaccine. If you've had a fever, your vaccine will be deferred. The vaccine is currently contraindicated or not advised in anyone who is pregnant and is a breastfeeding mom. This is because the vaccine has not been trialed in these groups. If you're eligible, then you can have it after your baby is born or you've stopped breastfeeding. Or if you intend to become pregnant in the future, you should wait for at least 2 months after your second dose of vaccine. Children under the age of 16 are also not eligible for the vaccine, except there's been mention of some neurological conditions where it may be beneficial, but this will be on a named patient basis. You will also be required to give informed verbal consent. The benefits and the risks of the vaccine will be explained to you clearly before you give consent, and you should not feel pressurized into giving consent. After the vaccination, you will have to be observed for 15 minutes. So you will be taken to a waiting area or a recovery area where you will be observed. Information about any possible reactions will be given, and any adverse effects should be reported to the UK Yellow Card reporting scheme. An appointment card for your next dose in 3 weeks' time will then be given to you. You may have some mild side effects, but there's no need to self-isolate, but you should follow the normal social distancing rules. Full immunity can take up to 7 days after the second dose. So as you can see from this slide, you will start building up immunity at day 12, but full immunity can take will be at day 28, provided you take your second dose. So it's very important to have those 2 doses. So don't miss your second dose. So what are the common side effects? So up to 80% of people will get some local side effects of pain, redness, swelling at the site of the vaccination. It's quite common, and they're very mild. Mild fever, headaches, body aches, and pains are also common, and up to 15% of vaccinees experience some symptoms, or some of these symptoms. These may last 1 or 2 days and resolve spontaneously. You can take paracetamol to help with your symptoms. If you coincidentally have symptoms of COVID, which, as Ameet mentioned, are the loss of taste, loss of smell, a continuous cough, and fever, then you should go and get tested. We still have some unanswered questions as to how long will the immunity last? Will I still be a transmitter? Will I need a booster? And what if the virus mutates? As things evolve, and things are evolving rapidly, we will get more answers. All the information given to you today will change as new vaccines and new evidence and information is available. So keep your eyes and ears open. So the take-home points are: the global pandemic continues to cause millions of infections and several deaths across the world. A vaccine to prevent COVID-19 will contribute towards controlling this pandemic. Scientists across the world have worked to develop a safe and effective vaccine. There is some evidence that vitamin D deficiency causes adverse outcomes in COVID-19. The government recommends that you take regular vitamin D supplements, and the recommendation is at least 400 international units or 10 micrograms daily. Now, if you were on the shielding list during the peak of the pandemic, then you are eligible for free vitamin D. So look at the NHS website on how to obtain this. As a GP, I cannot leave without giving lifestyle advice. Exercise, as Ameet mentioned, not only helps with the physical symptoms help you keep physically active and fit, but also helps with mental health. And we've seen during the pandemic, a lot of people have suffered from anxiety and stress. Eat healthy, maintain a normal BMI and blood pressure. Talking of blood pressure, I now hand you back to Ameet, who literally takes his matter to heart.
Thank you so much, Anuja. And this will start. I'm just going to stop your screen sharing so I can move back to my screen, if that's all right. Thank you. Anuja, so Rajvee, excellent that we've put these things, and I can see that there are masses and masses of chat content and lots of questions to answer. Before we go to Q&A, there are two aspects. First of all, we're going to just quickly look over the summary of things that we've discussed. We've talked about the COVID-19 virus and human beings. We've talked about the infection and the impact and what is a normal relationship with the vaccine and what is an abnormal, with the virus and an abnormal reaction to the virus, that we ourselves may not be fit enough to navigate the tsunami of the virus coming at us. And if we were, we would be happy. You know, we would be saying, actually, I'm healthy, give me the virus, I can get through it, and I'm okay. The problem is that the resources required, the emotional impact, the economic impact, those are things we as a human race are horribly struggling with. You know, Rajvee, you've lost your mother-in-law, and that tragedy. You know, my father passed away, luckily, just literally a month before the whole of COVID lockdown, and we were able to have a normal funeral. So those emotional and societal aspects of COVID-19, the resources of not having enough ITU beds, those are the things that we're struggling with, and that we've discussed those. And of course, there is a debate about lockdown for protecting the vulnerable and the NHS resources and the economy and our societal impact versus other people saying, hang on, you know, there are other ways of boosting immunity. One of them is to navigate COVID. And so those difficulties are there. We are saying that the place of research, the place of good debate, the place of transparently generating evidence. So MHRA looking at different tests, etc. NICE looking at different guidelines. World Health Organization actually looking at the burden of what's being infected. And of course, statistics are often difficult to interpret depending on what your denominator is, who's being tested, what are their symptoms, etc. There's a lot of data capture that the human race is not perfect at. If we knew everything about everyone all the time, that would be fantastic. But the three messages remain: stay aware, have awareness for yourself, stay calm, approach this not emotionally, but doing the best by each person's perspective, you for yourself and you for other people who may be vulnerable. And stay safe, of course, by being healthy and navigating safety for others as well. So I've talked about competing issues. Please make sure you understand whether you've got the flu or not. You know, have that rationale, have the flu vaccine, really important. That is a program that's been going for years to try and help us minimize the impact of that virus. And we're trying to roll out the COVID vaccine strategy, the same as the flu, the vulnerable most, and then the frontline workers, and then after that. So people have asked about cancers, diabetes. Of course, they should be having the vaccine, providing that there's no anaphylactic reactions and likelihoods of those. And then don't miss cancer and cardiovascular disease. So we've gone through the summary. I'm going to go through the thanks quickly. Thanks, Hope for Science, Hope for Leadership, like CAT8, doing community events, etc. Hope for Humanity. Look at you all. You've all arrived. You've all arrived to have this conversation. You've all arrived to have this incredible sharing, and thank you for that. Thank you. We're very lucky that we're blessed with the NHS. We're not sure all the economies of the world are that blessed, but that's an important thing. And of course, as Janes, we're always trying to do the minimum of harm. You know, for us, if we lived as Janes, lockdown wouldn't even be a thing, because we are non-materialistic, we are minimalistic, we are healthy and straightforward and don't have a large green footprint, and we would probably remain very healthy. So there's that Jane aspect. But just after this, just to bring it home, I've been given permission by Mukesh Bhai to share his story, and he's going to capitalize what happens to some of us that are vulnerable. So with that, Nimrod, I think you've got the embedded. Thank you so much. And just before we go to that embed, here is the place that we have got a lot of these videos of the Royal Free. The BBC were actually looking at us for months, capturing a lot of stories and details, so you can see what happens inside the NHS. So I'm going to pass it back to Rumit. Rumit, thank you so much for this stage and audience. And if you could take it back to the video of that personal sharing of Mukesh.
Potentially classic COVID.
The patient causing Tim most concern is 62-year-old post office manager Mukesh Patel, who has COVID pneumonia.
Hello. Yeah, so my name's Tim. I'm one of the consultants here. Just been looking through your notes and your x-rays and everything. How are you feeling now?
Still pretty terrible, to tell you the truth. For the last
couple of days, it just got worse.
And that was the breathing now as well? Yeah. And you work in a post office, is that right?
Correct.
Okay.
I believe I must have got it from there, because I can just go work, home, work, home.
Yeah, yeah.
I can't see where else I could have got it.
Yeah, yeah. And were people wearing masks when they came in, or not always?
Not always. There are certain amount of people with attitude, unfortunately.
Looks like this is a COVID effect on the lung now. So we know you've got COVID. The oxygen level was quite low, but is being maintained by the oxygen that you're breathing in, which is reasonable for the moment. But we do worry that it might deteriorate, and certainly some of the treatments that we can offer now are designed to try to stop it from getting worse. Do you have any questions?
No.
He's a 62-year-old man without major other pathologies who has works in a post office, and he's on day 13 of an illness which is proven COVID with a swab on day 5.
Because of growing concerns about his breathing, Mukesh is being moved into intensive care.
Essentially had high temperature for the first week but no respiratory symptoms, and then started deteriorating from a respiratory point of view at home, and essentially has come in and he's now actually day 13 of when his symptoms started. Yeah.
He's likely to move to intensive care, then he's eligible for REMAP-CAT trial as well. That has more treatment option for him.
Hello, sir.
Hello.
Welcome to ITU. My name is Barbara. I'm one of the nurses here. Barbara.
I'm frightened. Because I had a few family members who caught it, and they've been in ICU but on ventilators, and they didn't make it.
Mukesh will remain in the isolated COVID area of intensive care in case he needs extra breathing support. Mukesh and Saroj Patel have been married for nearly 39 years and have never spent any significant time apart.
The worst is not being able to see him here. I just can't imagine what he's going through. So that makes me more worried, more sort of anxious. I didn't expect him to go to intensive care. I thought he'd just be in general ward. I can't be there for him. That's what's killing me.
The computer has randomly assigned a treatment to Mukesh.
Randomization has chosen you to be on anticoagulation because it's a blood thinning medication. There is potentially a risk of bleeding, but we will keep monitoring you for that. Thank you.
Thank you.
Hey, Mr. Patel, you did it. You made it.
After 5 days on blood thinning treatment in intensive care, Mukesh has improved enough to be moved back to a ward.
Look at the sun outside.
Oh.
Very nice, right?
So nice.
It's a good feeling coming out from
Yes.
Mr. Patel, I'm Sonal. I'm one of the doctors. I saw you before you went to the ITU.
Okay.
Yeah, how are you feeling today?
I feel lovely.
Great.
I feel very good.
You look a lot better than what you were before.
When I went into the ICU, I'll be very honest, I was shaking. I didn't know whether I was going to make it. I think the trial drugs pulled me through. Got a second lease, that's great. Yeah. Thank you so much. Thank you, thank you.
Mukesh is medically fit to leave hospital, but as his most recent positive COVID test was in the last 14 days, he must continue to isolate to protect his family.
Isolate.